Good afternoon. Welcome to this e-grandround, exploring how we manage the sexual consequences of cancer and its treatment. I welcome you all to this e-grandround, as does my colleague Dr. Gail Dunberger, who's joining us from Sweden. What I want to be able to do is give you some insights in relation to how we manage the sexual consequences of cancer and its treatment, but there will be opportunities along the way for you to ask questions by posing them via Dr. Dunberger, and obviously we hope that you'll be able to join us in this regard. So can I have slide number 4, please? If you look at slide number 4, what you'll see is that in everyday life and in our normal populations, sexual difficulties are something that we do encounter from time to time, and it's useful to know this when we're comparing how cancer might actually cause sexual difficulties, in addition to the problems and issues that we might face as healthy men and women in our adult lives. This is data from the United States back in early 1992, where they did a cross-sectional survey of patients between people between 18 and 59 years of age, and what they found was that about a third of men and about 43% of women had reported some degree of sexual difficulty. 10% of men had difficulty either achieving or maintaining an erection, 15% of men had low sexual desire, 8% of men couldn't reach orgasm, and 30% of men experienced rapid ejaculation. And one thing that's quite important to recognise here is that the prevalence of sexual difficulties is very strongly age-related in any normal population. Next slide, please. Here in slide 5, you can see comparing what the sexual issues were for women in this survey. 32% of women reported a lack of interest in sex. About 14% of women had arousal difficulties. 7% of women reported sexual pain. And from a range of studies, we found about a quarter of women had difficulty achieving orgasm. And again, age remained a substantial risk factor for increased reported rates of sexual difficulties in both men and women. Next slide, please. If you look at this slide, what you can see is that the human sexual response cycle, which was first devised by Marsden and Johnson in the 1960s, indicates that cancer and cancer treatment can actually affect all different phases of the human sexual response cycle. So if you look over at the desire phase, you can see that body image changes, altered masculinity and femininity affected again by treatment, patients who experience anxiety or depression as part of their cancer diagnosis, those who experience fatigue as a consequence of radiotherapy and chemotherapy in particular, those who've got changes in their hormones as a direct result of their cancer therapy, particularly after breast or gynecological or prostatic cancer, for example. And then the side effects that we see here listed that can affect the ability to feel desire and to feel that others might desire you sexually. Things like the loss of hair, feeling nauseated and having problems with diarrhea and mucositis. So all of those side effects or impacts of cancer and cancer treatment can affect the desire phase of people's sexual response. And if your desire is affected, it's quite difficult for you then to become aroused when you're being faced with a sexual situation with a partner. If you then move on to the arousal phase, you can see again that the ability to get and keep an erection, for example, can be indirectly affected by changes in testosterone, can be directly affected by nerve injury to the pudendal nerve in the pelvis, by alterations in the cavernosal arteries, through scarring and fibrosis created by radiotherapy or by surgery. And in women, if you've got changes to the vagina in terms of shortening or narrowing created either by surgery or by pelvic radiotherapy. Likewise, with loss of vaginal lubrication, all of those can lead to sexual pain and again can adversely affect the ability to relax and enjoy arousal. If your arousal phase is adversely affected, then it's difficult for you to reach sufficient levels of arousal in order to achieve orgasm. And again, within the orgasmic phase, both anxiety and depression and the treatments for anxiety and depression, particularly anxiolytic drugs and antidepressants, they can all have a negative impact on the ability to reach a threshold to be able to have an orgasm. And even when an orgasm is achieved, the orgasm may be less intense and less enjoyable in its quality. Nerve damage can also cause problems in terms of ejaculation. So men may fail to have an ejaculation at all, or they may find that they have what's called a retrograde ejaculation, where the ejaculate passes backwards into the bladder rather than being expelled forwards out of the end of the penis. There can also be delays in being able to achieve an orgasm, or, as I say, loss of orgasm altogether. And then, as a consequence of all of those different impacts, we may find that the actual sexual enjoyment is reduced, or there may be some bleeding or pain after coitus, which again has an adverse effect on sexual well-being and enjoyment. Can I have slide 7, please?
Isabel?
Yes.
Could I ask you a question? This is a very good slide, I think. So how can you help women with reduced sensation after pelvic cancer to reach orgasm?
Thanks, Gail. I mean, the difficulty can be whether or not you actually ask the question about whether orgasm has been affected, because obviously within the clinic, in terms of follow-up, we often find that that's not a question that's very often asked. So I think the first point of contact to do is to be able to ask a question about whether any aspect of a woman's sexual well-being has been adversely affected by her cancer treatment. Once you've hopefully elicited the fact that she's had a change in orgasm, there are a variety of techniques and approaches that might be attempted. Usually they would be taken forward by someone who's got training as a sex therapist, or a psychologist or a nurse who's had additional training in cognitive behavioural approaches for sex therapy. And here what we would normally do would be, we would use a technique that's referred to as sensate focus, where what we're trying to do is help women through a series of exercises that she will carry out at home with her partner to explore different aspects of sensation and sexual arousal within her own body. So helping her identify different erogenous zones, what types of stimulation and touch are enjoyable to her versus those that don't elicit any response. She would be encouraged to try different types of lubricants that can help stimulate sensation. Often they are lubricants that are either warming or tingling lubricants that are available on the market. And in addition, we might suggest that she wants to consider, if it's acceptable to her, thinking about how she might use a vibrator, for example, because sometimes vibratory stimulation can help encourage orgasm where stimulation by oral sex or by fingers might not be sufficient.
Thank you, Isabel. Yeah.
Okay, shall we move on to the next slide now, slide 7? And what slide 7 illustrates is comparing it with the earlier slides where we were looking at sexual difficulty percentages in the healthy population. If we actually look at the literature that looks at the prevalence of sexual difficulties after cancer, you can see that the prevalence rates are generally higher. So, for example, a survey by Macmillan Cancer Support in the UK found that 43% of patients who were asked said that their sex life had suffered as a direct consequence of their cancer treatment. Within patients who've been treated for leukemia or lymphomas, it's about a quarter of patients that find that their sexual life has been affected. It's higher in patients who've had pelvic radiotherapy for cervical cancer. It's between 50 and 80%. And after breast cancer, usually in association with treatment-induced menopause, again, the prevalence of sexual difficulties can be as high as in 70% of women treated successfully for breast cancer. After prostate cancer, again, it's up at 70%, and that's irrespective of whether or not the prostate cancer is treated surgically or by radiotherapy and hormone therapy. And again, after rectal cancer treatment, you can see the prevalence, particularly for men, is about 86%, although we don't have a great deal of information about the prevalence of sexual difficulties in women who are treated for rectal cancer. So you can see from those percentages that it is actually quite a common problem, but not all patients will necessarily want to pursue direct help in relation to that, and therefore it's really the skill of clinicians that need to think about how we might find out whether sexual recovery is something that's important to that particular individual patient or couple. Can I have slide 8, please? We've looked at the previous slide in terms of those high-profile patient groups, and they're the ones that you would automatically think of, I think. But actually, the patients who are perhaps lower profile are those who've been treated for hematological cancers, particularly after the likes of stem cell or bone marrow transplantation. And those individuals often need advice on how to prevent infection, how to have sex safely during risk associated with thrombocytopenia, where there might be difficulties with vaginal or penile graft versus host disease. But other patients who are also neglected within the literature and where there's very little research are patients who've been treated for head and neck cancer, those who've been treated for cerebral tumours, those who've had amputations or limb-preserving surgery, which affects their mobility and their ability to adopt certain sexual positions, and teenagers and young adults, where, again, there's not been a great deal of research in that particular age group.
Isabel, could I ask you, we know pretty much about how surgery and radiotherapy affect sexual functioning in men and women, but how much is known when it comes to chemotherapy?
That's a really good question. You're absolutely right in what you've said, is that where we have got research, it's predominantly in the patient groups that are treated by pelvic surgery and or pelvic radiotherapy. There's far less written about the direct effect of chemotherapy, but I think it's true to say that the effects are mainly to do with whether or not it's safe to have sexual activity during periods where patients might be immunosuppressed or where their thrombocyte count has been significantly reduced. Generally, the sort of advice that we might give would be issues around how the use of barrier contraceptives can be helpful in reducing the likelihood of developing sexually transmitted infections while someone's immunosuppressed. And I think this is particularly important if the patient who's being treated is not in a long-term stable relationship but is perhaps still exploring sexuality with a range of different partners. Because what you don't know is whether or not you're going to contract a sexually transmitted infection in normal well-being, but obviously when you're immunosuppressed you need to consider that risk even more. I think the other reason that the use of barrier contraceptives can be helpful is obviously to prevent pregnancy, while someone might have reduced fertility but they may not be infertile at the time that they're engaging in sexual activity. So generally I think it's helpful for them to use a barrier contraceptive to protect themselves from an unplanned pregnancy, which obviously could complicate cancer therapy if they become pregnant during that period. I think the other thing that patients worry about is whether they may bleed more heavily associated with chemotherapy-induced thrombocytopenia. And again, patients often seek advice about how to have safe sex in terms of not having perhaps very vigorous penetration, but using a good lubricant to reduce friction and being gentle in terms of penetrative sex. The other area that is sometimes asked about, I suppose, is in relation to anal sex, and it's not just gay male couples who engage in anal sex. heterosexual couples may have anal sex as part of their sexual repertoire. So again, it's about perhaps advising individuals who do engage in anal sex that while they're immunosuppressed or while they're thrombocytopenic, it's advised not to have rectal penetration, because the risk of infection is higher when you're engaging in anal sex and you're immunosuppressed because of the bacteria that normally live in the lower bowel. And also rectal or anal intercourse can be dangerous if you are thrombocytopenic, because there's a greater risk of, again, damage and bleeding associated with that. I think the other chemotherapy-related problems mainly relate to things like fatigue and how you can help patients identify the period post-treatment when their fatigue might be at the highest, and maybe avoid, again, times when they're feeling very fatigued, because, again, the ability to continue to enjoy sexual contact might be reduced at that time. Does that answer your question?
Yes, I think so.
Okay.
Very good answer. Thank you very much, Isabel.
You're welcome. Can we have slide 9, please? I think what I often find patients and some nurses in particular asking about are the sorts of myths that seem to surround cancer and sexual activity. And one of the areas of myth, again, is around fear of contamination from radioactivity. So patients who've had pelvic radiotherapy may worry that they can pass radiation on to their partners. The only situation where you would avoid sexual contact in close proximity to radioactivity would be if you've been given iodine-131 and you're still considered radioactive and the radioactivity has not yet been excreted, then you would avoid sexual contact during that period. But patients who've had external beam radiotherapy, certainly there's no possibility of them passing on radioactivity. Some patients worry about cytotoxic contamination of the partner, which again links to the question that Gail put to us. There is a theoretical fear about being contaminated by the breakdown products of chemotherapy agents, but actually there is no research to indicate that this has ever happened. And I've certainly clinically never come across male or female patients whose partners have ended up with some degree of irritation or difficulty associated with sexual contact. Again, if you look at the half-life of the drugs that we use, that will give you some indication as to when the body might be excreting the breakdown products of chemotherapy. And I guess if patients are very nervous about that, then again they might be advised to use a barrier contraceptive, but there is actually no theoretical or research evidence to back up this area of advice. Again, patients worry about whether cancer can be passed on to their partner. This is not something that's possible, but some patients may ask you about that. Some patients worry that if they have cancer and they're on treatment that's meant to suppress their hormones, such as prostate or breast cancer, that having sex might lead to a surge in estrogen or a surge in testosterone. Again, there is no evidence to suggest that this happens, so we do suggest that sexual contact in those patient groups is perfectly safe. A more common fear is whether or not a partner might cause pain or cause damage associated with sexual contact. So again, it's about offering patients reassurance that it's quite safe to have gentle sex during treatment or after treatment. Some patients worry about the fact that they may have had sex in the past, and has that been the cause of their cancer? And obviously, where there are virally induced cancers such as HIV-related cancers or human papillomavirus-associated cancers, it is about actually talking through with patients the fact that HPV in particular is a very commonly encountered set of viruses, and that all sexually active adults are exposed to HPV, but not all sexually active adults will contract a cancer associated with that exposure. In HIV, it's about recognising whether or not you are in a higher risk group or whether you are having sex with someone who is HIV positive. And then again, it's about safe sex messages in terms of engaging in sex with the use of appropriate barrier contraceptive methods to reduce the likelihood of HIV transmission. And some patients do worry about fear of being reinfected with a virus if their partner they believe is the source of viral contract of cancer after successful treatment. And again, quite often that requires a conversation between the patient, their treatment team, maybe with advice from virologists and with a sexual counsellor who might help them work through that particular area of fear of anxiety. Can I have slide 10, please? What this slide demonstrates is perhaps how reluctant we are to talk about sex when we're reviewing patients in our outpatient or follow-up clinics. This was results of a study I undertook in pelvic radiotherapy clinics for women, and you can see that while bowel and bladder toxicity are discussed about 81% and 70% of the time, and there are a whole range of different topics you can see that are discussed. Right over at the right-hand side of that slide, in the turquoise bar of the graph, you can see that sexual issues were only raised in those consultations about 25% of the consultations that were observed. And the patients in those consultations didn't know why I was sitting observing the consultations. They just knew that I was interested in radiotherapy follow-up. But even though they were a higher risk group of patients, at risk from a high prevalence of sexual difficulty, in only a quarter of those consultations were any questions asked of those ladies. Can I have slide 11, please? And if you compare those figures with a male clinic setting, this data comes from a study I was involved in prostate clinics. One was in a radiotherapy setting, and the other one was in a surgical urology setting. And you can see that the prevalence of inquiry about sexual difficulties or sexual concerns was 52% overall in the radiotherapy clinics and 54% in the urology clinics. And you can see in the second line of that table that the main people asking questions about sexual recovery were actually the healthcare professionals, not the patients. The patients only asked questions in 4% of the radiotherapy consultations and 22% of the urology consultations. So even though, again, this is a high-risk group of prostate cancer patients, the question of sexual recovery wasn't addressed in around 48 or 46% of consultations. So again, we're still only managing to achieve just over 50% inquiry rates, but that still is a far better in the male patients than it is at 25% in female patients. Can I have slide 12, please? This is really just a reminder to those of you who've joined us on the e-grandround through the European School of Oncology that Dr. Gail Dunberger in Sweden is waiting to receive your emails, and feel free to ask questions and send comments in relation to this at any time that you would like.
I was just going to say that, Isabel. I have no questions yet, so please send your question. I'm waiting.
That's lovely. Can I have the next slide, please? What this slide is telling us is work by Leslie Shawver in the 1980s. And Leslie Shawver is a clinical psychologist based in MD Anderson Cancer Center in Texas. And back in the 1980s, as long ago as then, what Leslie Shawver suggested is that we should have a triage mentality to assessing patients for sexual difficulties. And what she suggested was that all patients need one question from us as clinicians. Some patients might need some brief information or advice, and a smaller number need brief counselling. So brief counselling might be only seeing a counsellor or a therapist for perhaps 5 or 6 sessions maximum. And it's a minority of patients, perhaps only between 10 and 12%, that might need access to intensive therapy. And intensive therapy would probably be either working with a clinical psychologist or a nurse who's had specialist training in sexual counselling, or perhaps seeing somebody like myself who works as a sex therapist. But it's not the majority of patients who need this level of involvement. But of course we don't necessarily know how many patients are being affected because we're not necessarily asking those questions in the clinic and in our follow-up services. Can I have slide 14, please? So one of the questions that I often get asked, and I know Dr. Dunberger has asked this within her practice in Sweden as well at the Karolinska, is what do we use to perform a sexual assessment? And I think there's two answers. I suppose one answer comes from the needs from a research point of view, and another answer is more a clinical answer. If you are wanting to be able to rely strongly on the kinds of questions that you ask, it's probably helpful to use established instruments so that you've got some degree of consistency when you're reviewing patients at regular intervals in their follow-up. So I've listed two specific research instruments which I know are used in some clinical settings as well to evaluate sexual recovery and evaluate interventions for sexual well-being that might have been introduced by clinicians. The first of them is the International Index of Erectile Function, which is, as the title suggests, purely used for predominantly erectile dysfunction, but it does have some questions about sexual desire and orgasm as well. And that's used mainly for patients, for male patients who've been treated where their erectile function will be affected. And then there's the Female Sexual Function Index, which asks questions about different aspects of female sexual response, including desire, orgasm, arousal in terms of vaginal lubrication, sexual satisfaction. And then most of you, I imagine, will be aware of the EORTC quality of life instruments that have been developed. And in many of those, including the breast cancer one, cervical cancer, prostate cancer, endometrial cancer and rectal cancer, they do have one or two questions in relation to sexual well-being. But it should be noted that very few sexual morbidity instruments have been validated for use in a cancer setting, and very few quality of life instruments that are developed in cancer have sufficient detail to use as a clinical assessment instrument. But there are some colleagues who are working with EORTC at the moment who are developing male and female modules specifically addressing sexual recovery or sexual adjustment after cancer. So that is research work that's going on at the moment across Europe to try and develop a specific quality of life module for sexual recovery and sexual well-being. So hopefully that will help us in the future. Can I have slide 15, please? What this slide shows is really that we use a stepwise approach to managing sexual difficulties that are brought about by cancer or cancer treatment. And the initial step really is, first of all, to identify the problem through assessment, involving the partner where that's acceptable and where there is a partner, and looking at how we help the patient communicate their difficulties and their anxieties about sexual recovery. If we identify a sexual difficulty, we then move on to step 2, where we will consider, for example, different drug therapies for erectile dysfunction, and those are some of the drugs that are listed there. Or we might consider whether, if there is somebody who has had a treatment-induced menopause or a treatment-induced testosterone deficiency that's adversely affecting their sexual function, then again, as long as it's oncologically safe to do so, we will offer them hormone replacement therapy to assist them with their sexual recovery. We might also consider step 3, where we are advising patients on the use of vaginal dilators if they've had either pelvic radiotherapy or if they have had pelvic surgery, particularly where there may be some vaginal reconstruction, where we're trying to again promote the development of confidence and maintaining vaginal health to assist with penetrative sex. We also commonly suggest the use of intimate lubricants, the use of vaginal moisturizers, the use of topical estrogens to help with treatment-induced hormone deficiency. But also on the male side, we may use alprostadil, which comes in two particular formats. There are alprostadil pellets, which are inserted into the urethra, and they're absorbed through the urethra into the cavernosal spaces, and by doing so, they help bring blood into the penis and can create an erection, usually after about 20 minutes of after administration. Or we can also try alprostadil injections direct into the cavernosal spaces. These two treatments are mildly invasive, as are the use of vaginal dilators, etc. But we would use the likes of alprostadil pellets or injections where oral drugs haven't been successful. If we've tried these different strategies and we're still not getting an optimal response for patients, we might consider step 4 interventions. These interventions can be used after we've tried drug interventions, or they can be used in addition to drug interventions in combination. And here we would use vacuum pumps, constriction rings, vaginal or clitoral vibrators for orgasmic difficulties. We might use a vaginal prosthesis if the woman doesn't have a vagina, but penetrative sex is still wished for. Or a penile prosthesis can be used by a male patient where he's got permanent impotence and isn't able to obtain an erection by other means. And then last but by no means least, we look at step 5 interventions, which are surgical interventions in terms of either vaginal reconstruction techniques or penile implants, which, as you can see there, come in different types, which again can be used where all the other aspects haven't been successful. And then across the whole of those different 5 steps, there is the contribution of psychological support, either through psychotherapy, sexual counselling, or psychosexual therapy to actually help patients with these different interventions. Can I have slide 16, please? So if we're looking at the sexual rehabilitation options that are available for men, we've already touched on a lot of these. I'll just go in a little bit more detail. We can use the oral PD5 inhibitor drugs. Sildenafil or Viagra is about to come off license, so it may well be that those drugs will be cheaper when other drug companies are able to make generic versions of Viagra. We can also obviously offer these other drug therapies such as tadalafil or vardenafil. The main difference between tadalafil and sildenafil or vardenafil are that tadalafil has got a longer half-life, so the duration of action of tadalafil is longer, and patients can therefore find that that reduces perhaps the performance anxiety or pressure to have sex within perhaps 1 to 4 hours of taking the drug, because tadalafil can last for up to 24 or 36 hours in the body and can still help produce an erection under the right circumstances. But it should be noted that all of these drugs still do require sexual stimulation. They're not aphrodisiacs, but they will help increase blood flow into the penis. Alprostadil and through the pellet or the injection, these are used generally where the oral drugs aren't successful. They're not as popular with men because men don't particularly like injecting themselves in the penis, which is understandable. And sometimes the alprostadil pellet is either not very effective or can sometimes cause a stinging sensation in the urethra as it's absorbed. But some patients do use these techniques still and find them quite useful. Vacuum pumps can be used in addition to the oral drugs. or they can be used where patients don't want to use drug therapy for some reason. They are a little bit more cumbersome to use, but many patients still find them very helpful. And they use a constriction ring once they've created an erection with the device to keep the blood in the penis for the purposes of being able to complete sexual activity. Penile implants are, as I say, used as a last resort where all other attempts have failed and the patient is fit enough and wants to pursue a surgical implant as an alternative. And psychosexual therapy can be very useful for a variety of sexual difficulties, including persistent loss of sexual desire, orgasmic difficulties, failed ED strategies where patients are being helped to adjust to non-coital alternatives of sexual enjoyment and expression, or for patients who are fearful of having lost masculinity or where there's distress in the couple. And a couple therapy approach is preferred. Can I have slide 17, please? This is a Cochrane review that was carried out in 2007, which is really just looking at the evidence base for sexual dysfunction following treatments for cancer. And what that indicates really is that most of the studies that they found through that review were actually interventions for men with erectile dysfunction associated with prostate cancer. So most of the research about interventions for sexual dysfunction are actually associated with prostate cancer treatment, and they're associated only with erectile dysfunction. Only one of the studies that was reviewed explored the effectiveness of a vaginal cream containing estrogen after radiotherapy for cervical cancer. But most of the studies that were identified were of poor methodological quality and had relatively small sample sizes, which is one of the difficulties when patients are asking you what research there is for the interventions that we're trying. The answer is there's very little out there except in erectile dysfunction after prostate cancer therapy. Can I have slide 18, please? Again, within this same review by Miles et al., the strongest evidence was for the PD5 inhibitors. There were negative effects, but they were few and mild in all but one trial, where there were a small amount of adverse events. There was some evidence that sexual counselling can improve self-administration of injections of alprostadil. So sometimes if you've got counselling that helps support men, they do better with intracavernosal injections than giving the injections alone. And there was some evidence that the vaginal lubricating cream reduced sexual dysfunction in the women in that one study. But there is definitely a need for more research. Can I have slide 19, please? If you look at sexual rehabilitation interventions for women, here we're mainly looking at the range of vaginal lubricants that are available for women who are experiencing sexual pain after particularly pelvic surgery and pelvic radiotherapy, but also women who are on hormone treatments for breast cancer, such as those who are given aromatase inhibitors in particular. And all of these vaginal lubricants can be used successfully to improve sexual pain and reduce friction where you've got vaginal dryness. We can also use vaginal moisturisers such as Replens and a relatively new vaginal moisturiser called Hyalofem, because again, neither of these contain any hormones, so they're safe to use after breast cancer and endometrial cancer. We can still recommend the use of vaginal dilators, although again, the evidence for the duration and frequency of use is not particularly plentiful. We again can use topical estrogen or the use of hormone replacement therapy for ladies who are rendered menopausal at an early age. And again, HRT and topical estrogen should be used up to the normal age of menopause, which is around 54 years of age, unless there is a contraindication in terms of a hormone responsive tumour. Psychosexual therapy, which both myself and Dr. Dunberger are involved in delivering, We will use for women who experience persistent loss of desire, those who are fearful of getting back to sexual intimacy again and are frightened to approach their partner, those who experience persistent sexual pain, those with secondary vaginismus where they develop vaginal spasm because of their experience of pain, and again those who either feel that they have lost their femininity or where there is distress affecting the couple. Can I have the next slide, please?
Isabel, I would like to ask you a question. How do we deal with the fear of topical estrogen? A lot of women are afraid of taking topical estrogen, even though they haven't experienced breast cancer.
Now, that's a really difficult question to answer, because even within the hospital where I work at the Royal Marsden, there are different opinions within the breast cancer team as to whether or not it is safe to use vaginal estrogens in women who've been successfully treated for breast cancer. What we generally suggest is that women who are on tamoxifen and are experiencing severe vaginal atrophy symptoms, we will try them on Vagifem or some other low-dose vaginal estrogen, and we will consider that the tamoxifen is likely to prevent any systemic effects of the low absorption from the vagina occurring. But actually, it's difficult to predict how much vaginal estrogen is absorbed into the general circulation. So where we've got women on tamoxifen, some of our consultants will support women who request help with vaginal symptoms to use a vaginal estrogen. But women who are on aromatase inhibitors, which is a much more severe version of estrogen suppression and control, most of our consultants aren't happy for them to try vaginal estrogens if they're on aromatase inhibitors. So if they find it very difficult to tolerate the vaginal pain and the changes that are brought about by aromatase inhibitors, then it may be that the women request to be switched back to tamoxifen so that we can then use Vagifem in those women. I don't know about the Karolinska Institute. Do you have a different approach, Gail?
I am at the Sahlgrenska University Hospital, but my experience is that even women with pelvic cancer, like gynecological cancer, anal and rectal cancer, are afraid of a topical estrogen.
Yes.
Is that your experience as well?
It is, but usually what I do is with cervical cancer and rectal or anal cancer, I usually explain to the women that because their cancers are not hormone responsive, as long as it's advisable for them to have vaginal estrogen, we don't think there are any safety concerns. So the only women that we would withhold vaginal estrogen from are those who've been treated for endometrial cancer or those who've been treated for breast cancer, and their consultants are not happy for them to have it. But generally those other women, we explain to them that it's quite safe for them to have vaginal estrogen because there's a very low systemic absorption of estrogen and because their cancers are not estrogen responsive.
Okay, thank you, Isabel.
You're welcome. Can I have the next slide, please? So we're now on slide 21, and this is really just to make you aware, if you weren't already aware, that there are now international guidelines about vaginal dilation, which were an international group that was led by Dr. Tracy Miles, who's based in Bath here in the UK. And these guidelines have brought together all of the published literature about the efficacy and appropriateness of the use of vaginal dilators after pelvic radiotherapy in particular. And these would be for any women having pelvic radiation, including those who are treated for either a rectal or an anal tumour, not just those having vaginal brachytherapy or those having treatment for cervical or endometrial cancer. But again, you'll read, if you get hold of these guidelines, and they're freely available, you can Google them, They're also available through the National Forum of Gynae-Oncology Nurses based in the UK. But what you'll find is that, the evidence base for the optimal duration and frequency of use simply isn't available to us yet, and we definitely need to encourage research funders to provide more funding for research in this whole area. Slide 22, please. So really just to reiterate what I've said, the evidence base for the use of dilators and for their impact is relatively weak, and we do know that compliance with regular dilation is actually quite poor amongst women, certainly that I see. What we ask women to consider is whether it's helpful for them to incorporate the use of a dilator into their sexual repertoire with their partner, but they can also use regular intercourse or the use of a vaginal vibrator or their fingers or their partner's fingers that are lubricated as an alternative, because a lot of women, I find, don't like using dilators. They find them very off-putting. And I think we need to discuss with women who are not and don't think that they will be sexually active in the future, if it's purely to maintain vaginal health in terms of being able to view the cervix or the top of the vaginal vault during a pelvic examination, then I think we need to discuss that very openly and honestly with women who are either virgins or who are not sexually active, because again, it may be that it's difficult for them to dilate for that reason alone. And again, I think we need to be able to discuss dilators for women who are in a lesbian or same-sex relationship, because again, they may not find the use of dilators acceptable, but again, that's something that we need to find the ability to discuss with these women. Can I have slide 23, please? So this is really just to give you a little bit of information about psychosexual therapy, because the term psychosexual therapy sometimes implies that we're only talking about a sexual problem that is predominantly psychological, whereas actually all sex therapists work with these three domains of sexual function, or the three factors or areas that affect sexual function. So we look at physical issues, so we're considering hormonal changes, blood vessel and vascular flow changes, neurological or nerve function changes, whether there are other physical illnesses such as diabetes that might also be causing problems, and what drug therapy the patient is on, which again can cause problems with sexual recovery. We look at the psychological response, so we're looking at anxiety, we're looking at depression, and we're looking at the treatments that they have for those conditions, and other concurrent mental health difficulties that might make psychological well-being a challenge for those patients. And we look at the couple interaction, because again, not all couple relationships are supportive relationships for sex. There might be fear, the couples may blame each other for the difficulties that they have. There may be abuse in the background of the couple or in a previous relationship, which again means that that couple or that individual may need further or additional psychosexual therapy and support. And we also look at three sets of factors when we're assessing patients who develop sexual difficulties that they can't overcome without help. So we look at what predisposes those individuals to not being able to adjust to sexual changes. And these might be things like previous sexual abuse or a previous history of sexual violence, such as rape. We look at precipitating factors, such as the cancer diagnosis and treatment, but there might be other precipitating factors, such as relationship breakdown. And we look at factors that maintain difficulties, such as poor couple communication or fear and anxiety in one or both of members of the couple. So again, these are the areas that we work with from a psychosexual therapy point of view. Can I have slide 24, please? This is a summary of work from Sloan Kettering in New York, carried out by Michael Critchman and colleagues. And what this was a retrospective study looking at patients who'd been referred to the survivorship program that Sloan Kettering develop and use. What they found was that 37% of the patients that they'd had referred had gynecological cancer, with endometrial, ovarian and cervical cancer being the most common. And the mean, or median rather, age of those women was just over 50, and 92% of the women were postmenopausal at the time they were referred. And the most common problems you can see that were presenting within these patients were dyspareunia or sexual pain, atrophic vaginitis, which, as Dr. Dunberger and myself were discussing a moment ago, is predominantly caused by changes brought about by either premature or natural age menopause, decreased sexual desire, and orgasmic difficulties in a minority of patients. Can I have slide 25, please? What's interesting in the results of this retrospective review was that they did give hormone therapy alternatives to 89% of those patients. They offered psychosexual counselling to just under half of the patients, and you can see they used vaginal estrogens in a third, and they used vaginal dilators in a quarter of those ladies. And at a median follow-up of 6 months, there was a 2/3 compliance rate in the women who attended this programme, and 70% of the women reported a subjective improvement in their symptoms. So there is some evidence that this integrated approach to managing female sexual difficulties after pelvic cancer can actually help these ladies, where you're addressing not only physical issues, but you're using sexual counselling in conjunction with biomedical interventions. Can I have slide 26, please? This is just some evidence-based really for psychosexual therapy or psychological interventions. And this is by Laurie Brotha, who's based in Canada. And this work is more recent than the early Cochrane review, which didn't find any evidence for psychosexual or psychological interventions. And what Laurie Brotha et al. Have found is that in their review of 27 studies from 8 different databases, they actually found a range of evidence from 1B, which are RCTs or randomised controlled trials, through to lower level evidence in terms of level 4 expert opinion. And what they found was that actually 19 out of the 27 studies that they reviewed were level 1B evidence, which is quite good. And what their analysis suggested was that there is increasingly some moderate support for the effectiveness and the feasibility of psychological interventions for sexual dysfunction after cancer and cancer treatment. So I think this indicates that with increased research and increased awareness, hopefully there are more patients that we'll be able to help with work that goes beyond a purely biomedical or drug-focused intervention for sexual difficulties after cancer and cancer treatment. Can I have slide 27, please? So this again, Gail, is just a reminder, isn't it, to colleagues who might be listening. I don't know whether you've received any further questions from any of our colleagues.
You have such an interesting talk here, Isabel. I'm sorry, no questions yet, but I hope that you will address Isabel soon with interesting questions.
Okay, thank you, Gail. Can I have the next slide, please? So this is really my last summary slide, and I suppose it's some take-home messages for all of us. And hopefully it's something that each one of us, irrespective of our level of expertise, will feel that we've got something to offer patients who might be experiencing sexual adjustment difficulties as a direct consequence of their cancer treatment. I think the first thing that I always try to remember is that modern cancer therapy is what we would refer to as multimodal. In other words, it's not common for us to see just one cancer treatment in the patients that we work with. Quite often they've had a combination of surgery, with or without radiotherapy, with or without chemotherapy. And in particular cancers such as breast cancer or prostate cancer, many of our patients are receiving hormone therapy as well. So if we're giving multiple treatments for cancer to control cancer, then this does increase the likelihood of there being sexual consequences. I think the other thing too is that we need to know who our very high-risk patient groups are. And from my point of view, and I think Dr. Dunberger would probably agree, the groups that we see most commonly are those who are treated for breast cancer, those who are treated for pelvic malignancies such as gynecological malignancies, rectal malignancies, and anal cancer. And I think we mustn't forget the patients who perhaps are treated for other types of cancer, but I think those of us who work with those high-risk groups need to consider how we're going to develop our confidence to become more adept at asking questions about sexual recovery as routine part of our follow-up. We need to be able to really increase the rates of routine screening and assessment for treatment-induced sexual difficulties so that we take the responsibility of asking patients rather than waiting for the patient to ask us. It remains our responsibility to make patients aware that this could be a consequence of the treatment they've had, rather than waiting for patients to discover that as a problem 2 or 3 years after their cancer treatment has ended. And I think we need to increase the knowledge and the provision of specialist services and referral pathways for sexual rehabilitation within oncology and within our cancer centres. And those were really the main take-home messages that I wanted to leave you with today.
Thank you very much, Isabel, for a very interesting talk. I would like to address a question to you, and I hope that we will have more questions coming in. And you said all patients need one question. That's really true. And we know as health professionals that we have to be more proactive and taking the initiative to inform, to ask and to help our patients to regain their sexual health. So how do we achieve this change in attitude, Isabel?
That's a $50 million question, I think, Gail.
I know.
I mean, you know the literature as well as I do. I've been looking at the literature right back to the early to middle 1970s, and all that time it's indicated that we are still reluctant to ask questions about sexual recovery. And I think, for me, there's 2 main ways in which we can help practitioners build confidence. I think, first of all, we need to make sure that training is available, not just important information as we have had in this e-grandround today, which is obviously an important place to start, but perhaps training that helps them develop the communication skills to ask sensitive or difficult questions of patients and to feel confident that they can answer those questions when the answers come back at them from patients. And I think one of the ways to do that is actually through providing better access to clinical supervision in our places of work, and maybe setting up small discussion groups, or setting up, what do they call them? Action learning sets, or mentorship groups, where someone who is confident and experienced, such as yourself, can work with those who are still learning and help them role play and practice asking questions of patients so that they become more confident at asking questions about sex, the same way as they ask questions about bowel or bladder function, for example. So I think it's a mixture. It's a mixture of taught information, but also I think it's about helping them develop the skills. And sometimes that's easier to develop when you're shadowing people or you're being mentored or developed in a small group, rather than through formal education.
So could you give an example of a question that you could ask the patient when you start to talk about sex?
Yeah, I think so. I mean, sometimes I say things like, it's almost like you need to be able to create permission for the patient to feel that it's all right to ask a question. So I often say things like, many patients who've had your type of surgery have fears or worries about what it might feel like to be getting back to sexual activity again after their surgery. Is that something that is worrying you?
That's true.
And you know, you can replace surgery with radiotherapy or with chemotherapy, or you can replace surgery, chemotherapy or radiotherapy with the type of cancer. So you might say, you know, many women after cervical cancer worry about getting back to sex with their partner again. Is that something that you and your husband or you and your partner are worried about? Is there anything that we can help you with?
That's true. Very good answer, I think. So thank you, Dr. White. I will check if there are any questions.
Okay.
Your talk was very informative, so no questions, Isabel.
Okay. Well, maybe people will email questions in, and I'm very happy for yourself, Gail, to forward any questions that might come into your email address. And I'm happy to answer individual emails if that's helpful to people that might have joined us today.
Yes, I'll do that.
Thank you very much.
Thank you very much.
Bye.
Bye.